Well, hello there this afternoon. I'd first of all like to thank Cecilia and Bill for inviting me to this talk, which is entitled Treatment of Unexplained Infertility, What is the Evidence? This topic is really near and dear to my heart, as some of you may well know, as I spent a lot of my academic career before coming to ASRM conducting two large infertility trials on unexplained infertility. The FAST trial was for couples with unexplained infertility, the female partner under the age of 40, and the 40 trial was for unexplained infertility couples, the female partner 38 to 43 years of age. While the bulk of my talk is not going to be on those trials, I will certainly talk a bit about them as we get into this discussion. What's really satisfying for me is that over the last year and a half, the ASRM practice committee has been working on a document to produce a guideline for the treatment of unexplained infertility. They performed a systematic review of the literature, graded the literature, and came up with recommendations. And so today I'm going to follow much of that document, and what I will share with you are the recommendations from the practice committee's document that has been finalized recently. It has been sent off to Fertility and Sterility, and it should be online within the next 4 to 6 weeks. So I have nothing to disclose. I have no relevant financial relationships with any manufacturers of pharmaceuticals or medical devices. And as I told you, the ASRM Practice Committee has finalized a guideline, and I will be sharing with you conclusions and recommendations to be presented. I will, of course, not share with you the bulk of the studies that came to these conclusions. However, I will be sharing with you some of the more significant and the better trials that helped us make such decisions. So, learning objectives. At the conclusion of this presentation, I hope you will be able to consider the couple with unexplained infertility, the female partner, less than or equal to 40 years, and list the most important factors to be considered when deciding what are the best treatments. To describe key studies that provide evidence for and against the use of specific treatments, and discuss which of the following treatments has evidence available to support its use. And you can see the treatments that I've listed here. And finally, to consider describing a treatment paradigm that is supported by the literature. Now, when we consider the couple with unexplained infertility, I'd like to, as a backdrop, just review one demographic study that examined 200 couples who began to initiate their first attempt at pregnancy and were followed for a year after that. And as you can see in this study, had the best success, and we all know that, are the first couple of cycles. In fact, their chance for pregnancy in the first two cycles was 30%. Success dropped, and by 6 months, 73% of these couples were pregnant. But the chance for pregnancy following that was about between 5 and 10% per cycle. By a year, 80% of couples had become pregnant, but you can see here, and this chance for pregnancy after that was 3 to 4% per cycle. And then we're going to come back to that time and time again, because as we think about treatments, if there's no comparison to expected management, we at least want that chance for pregnancy to be better than 4% per cycle. So I like to consider the couple with unexplained infertility, and I've chosen a couple, both 33 years of age. They've attempted pregnancy for 1 year, and they were diagnosed with unexplained infertility after completing an evaluation. And I know I always heard this, and I'm sure you've heard this from time to time. The couple are really frustrated with this definition of unexplained infertility, because they say, if it's not broken, how do you fix it? Well, I explained, and I've always explained, and I'm sure you do similarly, that we fix it by increasing the odds to get pregnant, or as I used to say, upping the ante. We know that with expectant management for a couple with unexplained infertility, so a normal sperm count, a maximum of 200 sperm will get to the fallopian tubes after intercourse. And in that couple with unexplained infertility using expectant management, we expect that the vast majority of them will be releasing 1 egg, and realize that there's a high baseline aneuploidy rate that limits pregnancy. So if this couple has unexplained infertility, then we're going to increase the odds by perhaps IUI alone. We know we could get 5, 10, 20 million or more sperm to the fallopian tubes with IUI. Or maybe ovarian stimulation alone. the idea that we get the patient to ovulate more than one egg, increasing the chance that one of them may be euploid. Or we might do a combination of both, or ultimately we may do IVF, where we would hope that by increasing the number of embryos formed, that one or more of them may be euploid. But of course, we only want one that we transfer. So for this couple, we ask the question, which of the following therapies is appropriate? And you can see those that I have listed here. Now, in 1998, David Guzik performed probably the first systematic review of the literature for studies that had been done before that time. He showed, similar to the demographic data of Zinnemann, that the chance for pregnancy in those studies that had an expectant management arm was less than 4 or 4% per cycle. Again, we'll get back to that again and again. Now, many of the studies for Clomiphene IUI, Gonadotropin IUI, and IVF at that time were certainly not randomized controlled trials, but rather were cohort studies or reviews of database data. A recent study from the Netherlands looked at 38 centers and 5,000 couples with unexplained infertility, and they showed that after an infertility workup, if they used expectant management, 21% had a natural conception after 8 months. For those who were not pregnant in a half year, 20% of them became pregnant in the next year. For those who were not pregnant in a year and a half, only 13% subsequently became pregnant in the following year. So we realized that the chance for pregnancy with expectant management is low. In European practices, they often use expectant management in those couples deemed to have a higher success. But as you know, in this country, it's hard to do studies with expectant management arms because it's hard for us to justify that. So when we do our systematic review of the literature, we hope that the level of evidence that we use is based on randomized controlled trials or well-conducted systematic reviews or meta-analysis of homogeneous RCTs. In the past, we had to depend on well-designed controlled trials without randomization or cohort or case control studies. But I'm going to show you that the task for analyzing the literature was made relatively easy for the practice committee and this task force because we have now a large number of randomized controlled trials that have looked at various aspects of treatment of unexplained infertility. And these are some of those that we're going to see throughout the rest of this talk. For example, I believe that the first really good randomized controlled trial was by the NIH Reproductive Medicine Network, Guzik's trial, where in 1999, they presented a study where about 250 couples in each arm were examined, and they compared intracervical insemination to IUI, to FSH intracervical, to FSH IUI. Intracervical examination was their really use of an expectant management arm with knowing that it was actually done. So it was their surrogate for expectant management. You can see Bhattacharya's study listed here. And this is a well-known study that looked at Clomiphene alone versus IUI alone versus expectant management and has given us some good information to make our decisions. Stur's RCT from the Netherlands examined gonadotropin IUI versus expectant management. The FAST trial looked at conventional IVF treatment or conventional treatment versus fast-track to IVF for couples with unexplained infertility. And all of these are great studies. One that I looked forward to for a long time was Cindy Farquhar's study from New Zealand, where she performed a randomized controlled trial and looked at oral ovarian stimulation, mostly clomiphene, I'll show you, with IUI compared to expectant management. So you can see there are a number of trials that have been performed that helped us make decisions in our conclusions of the questions we asked for treatment of unexplained infertility and for the recommendations that were made. Now, when we perform a systematic review, it's not just about what treatment has the best success, and you all understand that. It's always, you know, the first thing people do when we do the call out the different randomized controlled trials is to look at one success versus another success. But we know that the type of protocol is important. For example, a mild gonadotropin stimulation is very different in outcome than a moderate gonadotropin stimulation, which may have better success, but certainly has high rates of multiple births. The ease of treatment. One study that I'll show you that looked at gonadotropin IUI compared to Clomiphene IUI, it was the one study that was more successful without multiple births, but they had to aspirate the follicles of patients before they gave them HCG if they had 3 or more follicles. So you look at ease of treatment, that certainly, with everything else that goes to gonadotropin IUI, does not make that treatment any easier. Safety is critical. I'm going to show you some horrifying data of the early studies of gonadotropin IUI and the multiple births, and study design is critical as well. So let's begin to look here. And we'll start with this no treatment, 4% per cycle, as the background to the different treatment choices. So I'm going to examine these treatment choices over the next few moments. But rather than start at the top at IUI, I'm going to start with IVF, because I think it's a key question. As IVF treatment success gets better and better, it is key to say, well, why not just do IVF if couples can afford it? Now, if we look at Farquhar's data, the U.S. IVF success rates, for the last 2 years in 2015, the 41% of couples became pregnant per oocyte retrieval, but the cumulative live birth per patient was nearly 70% of couples. This is huge. The success rate continues to be good, even at up to even age 40. But at under 35, the success at 70% cumulative is really, really good. And we can see that for the most recent data that's been presented, the success rates are very similar, at nearly 70% per cycle and over 50% for 35 to 37-year-olds. On the other hand, we still have this challenge. And the challenge that we have is the percent of multiple births per intended pregnancy. And 17% still is unacceptable. When we think about the option of immediate IVF, I think we're getting closer, and I'll show you the recommendation from the practice committee is not there yet, but I bet this will change. We know that the USA success rates are sufficiently high and much higher than for other treatment options, but the challenge that we have are the twin and high order multiple birth rates remain unacceptable at 16% and 0.3%. Now, when we look at the literature that compares IVF to no treatment at all or other successes, largely the studies that were performed were done before 2000 when the IVF success rates were 15 to 20% per cycle. So that's really not that helpful. When we look at the Cochrane reviews, there are two, one in 2010 and one in 2015, and they came to the similar conclusions that there was insufficient data to suggest that it was obvious to go immediately to IVF. Now, there are 3 other studies that come into the mix of recent years, and they've examined IVF compared to other treatments. And we can always say, are these treatments really fair comparators? For example, this study of Bensdorp from the Netherlands compared single embryo transfer IVF to modified natural cycle IVF versus controlled ovarian stimulation IUI. And you can see that they had up to 3 cycles of single embryo transfer IVF, 6 cycles of natural cycle IVF, and 6 cycles of controlled ovarian stimulation IUI. Their success rates were essentially the same, and they concluded that IVF strategies were non-inferior to COS IUI, and there seems no reason to abandon COS IUI as first-line treatment. Now, again, is this a fair comparison? It may well be, and in that case, it certainly gives credence to continuing with COS IUI. This is a study from the UK in Nandi. They compared 3 cycles of controlled ovarian hyperstim and IUI, about 100 patients, to 1 cycle of IVF. And again, they concluded that singleton live birth rate with one cycle IVF was not significantly different than 3 cycles of COH IUI, and therefore they would begin treatment with COH IUI. So the systematic review of the literature for immediate IVF, the recommendation is there is insufficient evidence to recommend first-line IVF for unexplained infertility over expected management for 6 months or a limited course of OS IUI. So that's for immediate IVF. Now, I will tell you that they have an exception, and that is women over 38 years, and this is based on the outcome of our 40 trial for women 38 to 43 years. And they say the recommendation is that there is good evidence that immediate IVF in women greater than or equal to 38 years of age may be associated with a higher pregnancy rate and shorter time to pregnancy as compared to a strategy consisting of OS with IUI treatments with either oral medications or gonadotropins prior to IVF. It's kind of interesting. In that study, all couples began treatment with either 2 cycles of Clomiphene IUI, 2 cycles of Gonadotropin IUI, or immediate IVF, and then, if not pregnant, went directly to IVF in either arm, as long as they showed a reasonable chance for success. And what's really interesting is that for those couples who started treatment with Clomiphene IUI or Gonadotropin IUI, who became pregnant, 80% of their pregnancies were not from either of those first 2 treatments, but rather were from immediate or were from IVF, which I felt really helps us when we're talking to those couples with perhaps, especially at 40 and beyond, one last chance for pregnancy. So IVF for all others will be a reasonable option for routine initial treatment of unexplained infertility when it's routinely available, the costs are affordable, and when multiple pregnancy rates are lower by standard practice. Now, there's the exception because we all have couples who are seeking less invasive initial strategies, and so they may not ever want to go immediately to IVF. So until then, we still ask that question: which alternative treatment or treatments meet sufficient criteria for efficacy and or an acceptable multiple birth rate to warrant a place in a routine treatment paradigm? So let's go down this list. And it won't take long, I promise you. But it's, I think, very helpful to examine them individually. So IUI alone. In 2012, a Cochrane review of 14 RCTs looked at IUI compared to IUI with ovarian stimulation. And they demonstrated that ovarian stimulation added significant success to the IUI treatment, suggesting that IUI alone probably was not that helpful. When you looked at the Reproductive Medicine Network RCT of David Guzik, when you looked at, in that, of the 4 arms, the IUI arm was only 4.5% successful per cycle. And as you remember, the no treatment at all is right around 4% per cycle. Bhattacharya's study looking at IUI showed that 23% of couples in IUI only arm became pregnant over 6 cycles, and this was only 3.8% per cycle. Again, no better than no treatment at all. So when ASRM systematic review covered the entire literature of IUI alone, it is not recommended to perform IUI in natural cycles for the treatment of unexplained infertility. It is less effective than ovarian stimulation with IUI and not more effective than expectant management. Now, of course, there is the exception of a couple where there is sexual dysfunction, but short of that, IUI alone, increasing the number of sperm, does not seem to increase the chance for pregnancy. Now, what about Clomiphene alone? I think we probably all have had patients who say, you know, I can't afford anything now that you tell me that that I have unexplained infertility. I can't afford IUI. I can't afford IVF. So why not just give me the fertility pill? And I think that you'll see that this analysis will help us all as we talk to those couples in the future. It's always challenging not to give them the fertility pill, Clomiphene alone. But on the other hand, it's helpful to have data that tells us that that's not going to be effective. So let me show you the data. The Cochrane review of 7 trials, 5 with clomiphene citrate, shows that pregnancy rates were not enhanced. Bhattacharya's study from Scotland, as you remember, included clomiphene citrate versus IUI versus expectant management, and clomiphene citrate alone was no better than expectant management. So in that study, it was not better. When we looked at the bulk of the literature, including these two, it is not recommended to use clomiphene citrate with timed intercourse as a treatment for unexplained infertility, as it is no more effective than expectant management. We did the same review of the literature for letrozole, and our recommendation is the same, that letrozole alone does not increase the chance for pregnancy. And for me, and if I were back in practice, I think this would really help to be able to tell the patients, no, the fertility pill will not enhance your chance for pregnancy. A systematic review has shown that. What about gonadotropin ovarian stimulation alone? We know that we have a greater chance for stimulating more follicles, so it would seem that that might be a reasonable chance for a treatment. Well, if we look at this, the first thing that I can tell you is that there are no studies that have compared gonadotropin ovarian stimulation to expectant management for unexplained infertility, except the Reproductive Medicine Network trial, if you remember, has a intracervical insemination arm, and that was their surrogate for expectant management. In fact, we know, of course, then that it happened, that sperm got to the cervix. If you see in the Reproductive Medicine Network trial, gonadotropin with intracervical, so with essentially expectant management or a natural cycle, was only 4% per cycle. Intracervical in that was 2% per cycle. So really, that 4% per cycle for gonadotropins with intracervical insemination did not enhance the chance for pregnancy at all. And even though the pregnancy rate wasn't higher with gonadotropins essentially alone, there were still multiple births, and there was one set of quads, one set of triplets, and 20% of twins and ovarian hyperstimulation. So truly, this is not a reasonable treatment. So for gonadotropin ovarian stimulation alone, it is not recommended to use gonadotropins with timed intercourse in the treatment of unexplained infertility. Studies report either no difference in pregnancy outcomes compared to ovarian stimulation with oral agents alone or natural cycle, and a higher risk of multiple births. Now, if we've just said IUI alone, more sperm alone doesn't do it, more eggs alone doesn't do it, and more eggs alone by clomiphene or gonadotropins doesn't do it, what about the combination of the two? So let's look first at clomiphene ovarian stimulation and IUI. When we look at the systematic review of the literature of David Guzik, a meta-analysis of Costello in 2004, and a 2012 Cochrane review, and even our FAST trial where 503 couples got at least one cycle of clomiphene IUI. One of the things that amazes me when I look at the entire literature on this topic is there's one thing where the success rate has never been different, and that's clomiphene IUI, at least in the literature. It's always right around 8% per cycle. And we know that that is greater than no treatment at all. So off the bat, clomiphene IUI does enhance the chance for pregnancy, and you might say 8% is still not that high, and you're correct, but it is at least seemingly double the baseline pregnancy rate. One of the studies that I looked forward for years was to have a study where oral clomiphene citrate with IUI was compared to expectant management. So I was really excited when Cindy Farquhar told me that she was doing that study. I told her we were at a meeting at the WHO, and I said, Cindy, you know, the study, we were talking about the FAST and 40 trials, and I said, you know, the study that really needs to be done is clomiphene IUI versus expectant management. She said, we're in the middle of that study, and we'll have it done within the year. And so I really looked forward to the outcome and was pleased to see that when they compared 101 couples who had oral clomiphene citrate primarily, there were 7 couples with letrozole, to expectant management, that the chance for pregnant live birth rate for the treatment was 31% versus 9% for those with expectant management. And their conclusion was that IUI with ovarian stimulation is safe and effective treatment for women with unexplained infertility. and an unfavorable prognosis for natural conception. So if we look at the same time in the Netherlands, they compared gonadotropin IUI to clomiphene citrate IUI over 4 cycles, and they showed that there was no statistical difference in between these 2 treatments, and clomiphene citrate for IUI remains the best first option. Now, you have to understand also that in the Netherlands, they have very mild treatment of FSH IUI. But still, we're going to get back to that in a few moments. This is another study that in the way they practice it, and that clomiphene citrate makes the most sense when performing IUI. Now, the AMIGOS trial, the NIH Reproductive Medicine Network, compared gonadotropin IUI to clomiphene citrate IUI and letrozole. And yes, the pregnancy rate was higher with gonadotropin, the cumulative pregnancy rate, than the other 2 treatments. But again, look here at the multiple births with gonadotropin IUI. It was 24 sets of twins and 10 sets of triplets. Again, this is an unacceptable pregnancy rate or a multiple birth rate when we consider treatment for IUI. And therefore, in that study, clomiphene IUI remains the first-line treatment for unexplained infertility. So when we think about clomiphene with IUI, it is recommended to use clomiphene IUI with IUI in treatment of couples with unexplained infertility. The evidence is A grade, strength of recommendation is strong. Did the same analysis for letrozole, and the recommendation was that it would be a good alternative treatment with similar quality of evidence and strength of recommendation. So clomiphene ovarian stimulation in IUI remains a reasonable first-line treatment option for couples with unexplained infertility. Now let's look at gonadotropin ovarian stimulation in IUI. I showed you that with the initial systematic review of the literature that David Guzik published in 1998, the 20.7% pregnancy rate per cycle existed in those studies for gonadotropins. Those were not randomized controlled trials. They were cohort and database studies. But the challenge is, from the very beginning, so that's in 1998, in the series of patients that were published by Gleicher in New England Journal, believe it or not, in 2000, there were 441 pregnancies in their gonadotropin IUI cohort, of which 88 sets of twins, 22 sets of triplets, 10 sets of quadruplets, 5 sets of quintuplets, and 2 sets of sextuplets existed. Imagine that. I mean, to me, that is horrifying and should have been the first evidence that this is a treatment we don't want to consider for a long period of time. Dickey studied, again in New England Journal, 2001, published a series of patients, 294 pregnancies, where 41 sets of twins and 20 sets of higher order multiples, at least 1 quintuplet. So from the very beginning, the treatment of gonadotropin ovarian stimulation IUI was really complex and was included these really high-risk multiple births. And much of the studies that have been done since then have been to try to limit them and to use this treatment. The Reproductive Medicine Network trial that David Guzik published in 1999, again, compared intracervical to intrauterine insemination to FSH intracervical and FSH IUI. And you can see the only one with a significant increase in pregnancy rate was the FSH IUI. This was done in advance or before the study of Gleicher that had the horrifying high multiple births. And the conclusion here was that, in fact, of all these treatments, this is the only one that would be of benefit to couples. Yet they had 2 sets of quads, 3 sets of triplets, and the pregnancy rate, when you look at the per cycle pregnancy rate, was only 9% per cycle. That's no different than the 8% that has been shown in study after study after study. And I already showed you that when used in the FSH intracervical, there was 1 set of quads and 1 set of triplets. So using a standard dose of gonadotropins, 150 IU, it's just impossible to think that you're not going to have these high-order multiple births. So then the conclusion was we need to go to mild stimulation gonadotropins with IUI. And there are a number of studies in the literature that we considered in our recommendation, but these are two. Dankert compared Clomiphene IUI to Gonadotropin IUI in 2007 and showed that the success rate was very similar. And Sturs had a large study very similar to the FAST trial where they compared controlled ovarian stimulation, mostly gonadotropin and IUI, to expectant management, and they showed no difference from expectant management in success rate. This was the recent study that was the one study that showed that in fact gonadotropin IUI was better than Clomiphene IUI. But you'll see the note at the bottom of the slide here, where if they had 3 or more follicles greater than or equal to 14 millimeters, they either performed selective ultrasound aspiration or cycle was canceled. And my sense is if you have to do that to add it to the injections and the ultrasounds and the complexity of treatment, then it's hard for me to believe that makes this treatment worth performing. I already showed you the Amigos trial, gonadotropin IUI to Clomiphene IUI compared to letrozole. And as we've said, gonadotropin IUI continues to have an unacceptable multiple birth rate, particularly the high order multiples. And I've also shown you this, again, another comparison of FSH IUI to Clomiphene IUI, 4 cycles each. And again, Clomiphene IUI remains the best first option. So now I'd like to show you some of the data of the FAST trial that I spent a long time in my career conducting. And this was a study of 503 couples that came to us with unexplained infertility. So they had a complete evaluation when I was at the Beth Israel Hospital and did my care at Boston IVF. So they had a complete evaluation at Boston IVF, and they were found to have unexplained infertility. We then and none of these patients had had any treatment for infertility before that time. So the 503 couples were randomized to either a conventional arm or a fast track arm. And all couples got clomiphene for 3 cycles with IUI with a dose of 100 milligrams of clomiphene in both arms. If not pregnant in the conventional arm, couples then got up to 3 cycles of FSH IUI. And if not pregnant, they got up to 6 cycles of IVF. This study was able to be performed because of the Massachusetts mandate for insurance coverage of in vitro fertilization and our partnership with the 3 insurance companies that would allow this to be done. So in the conventional arm, they ultimately had up to 6 cycles of IVF, 4 that were fresh cycles. But the fast track arm, if not pregnant after 3 cycles of Clomiphene IUI, then they skipped gonadotropin IUI and went directly to in vitro fertilization up to 6 cycles. Now, one of the remarkable things, and I think this is something that's helpful for many couples, but for sure not all couples, is that 76% of all couples who were randomized into this trial took home a baby at the end of the study. To me, that is really reassuring. It was the same whether they started treatment with conventional or fast track arm. Now, and what that tells us is that IVF is the great equalizer. If you're able to get IVF, once you get to IVF, then you'll get pregnant as will anyone else who's having IVF for unexplained infertility. But the difference is this. We can see that at the end of the trial, their success rates were the same. But for those in the fast arm, they had 25% fewer cycles, which is huge compared to the number of treatment cycles that were had by couples in the conventional arm. When you look at the per cycle pregnancy rates, again, the Clomiphene IUI and the FSH IUI pregnancy rates were very similar and not that different than was seen in the Reproductive Medicine Network trial of FSH IUI. You'll see here that the 30.7% IVF success rate reflects the time that this study was concluded. And today, if in fact that's 40% per cycle, or if we did a cumulative, you can see that it would probably make the outcome of our study even more significant than it was. When we looked at the time to pregnancy, those patients who were in the fast arm became pregnant at a much faster rate that was statistically significant compared to those in the conventional arm. At the end of the study, we also had, with the 3 insurance companies, it took them a year each to do a complete analysis of every charge that went into every couple from the time that they were randomized into the trial to the time that they took home a baby from the hospital or dropped out of the trial. And you can see that the charge per delivery was $10,000 greater in the conventional arm compared to the fast arm. Our conclusion of the FAST study was, in fact, that we did not believe that there was a role for Gonadotropin IUI in treatment of unexplained infertility, at least the routine treatment. When ASRM systematic review was performed for gonadotropin ovarian stimulation with IUI, and when referring to conventional dose, it was not recommended to use conventional dose gonadotropins with IUI in the treatment of unexplained infertility. Most studies associated with improved pregnancy over ovarian stimulation IUI with oral medications are associated with a higher multiple rate. What about low dose? It is not recommended to use low-dose gonadotropins with IUI in the treatment of unexplained infertility. It is more complex and expensive and likely no more effective than ovarian stimulation with oral medications with IUI. Clomiphene, people will often ask me, what about clomiphene and HMG? While I did not show you the analysis here, it was no different than with gonadotropin by itself. Weight of the evidence suggests that there is no role for gonadotropin ovarian stimulation and IUI in the routine treatment of unexplained infertility, particularly in the U.S. So if we look at a treatment paradigm, if you're in Europe, you may well start with expectant management or observation, but we know that chance for pregnancy is 4% per cycle. Our analysis of the literature suggests that it's reasonable to begin treatment with 3 to 4 or so cycles of clomiphene IUI and then move on to in vitro fertilization. But we have to realize that the chance for pregnancy with clomiphene IUI, although is certainly better than no treatment at all and has been proven to be a reasonable alternative, it's still only 8% per cycle. So the question we have is, how do we fill this gap? And what will it be? Mild stimulation IVF? That's a lot of trouble for a relatively low success rate. What about clomiphene IVF? What about clomiphene in the vaginal incubator? And we certainly all hope that the future will bring us more treatments that are more accessible to our couples at all socioeconomic levels and have a greater success than clomiphene IUI. Now, there were some other findings of this study. In one particular, we looked at the number of IUIs to be performed. And from the literature, our recommendation was that for IUI treatments, it is recommended that a single IUI be performed between 0 and 36 hours relative to HCG injection and oral ovarian stimulation with IUI treatments. Now, I say this tongue-in-cheek. This is what the committee came up with. It's a great conclusion. And for sure, the literature shows that a single IUI is as good as a double IUI. In the FAST trial, for all 500 couples that received clomiphene IUI, we used ovulation predictor kits. And my sense has always been that let Mother Nature call it, tell us when to give, when to inseminate. If the patients did not have an LH surge by day 18, well, then we brought them in for an ultrasound and would give HCG if they had a follicle that was ready. We did not find literature enough to make comments on ovulation predictor kits in an LH surge timing based compared to HCG, but there was literature as shown here for HCG. So conclusion of the systematic review of the literature. The treatment of unexplained infertility is by necessity empiric. For most couples, the best initial therapy is, of course, typically 3 or 4 cycles of ovarian stimulation with oral medications, clomiphene citrate or alternatively letrozole, and IUI, followed by IVF for those unsuccessful with OS IUI treatments. So I thank you for the opportunity to provide my thoughts and the recommendations of the guideline committee for this guideline, which should be out shortly. Thank you.
All right, everybody. Thank you so much, Dr. Reindollar, and we'll now open up the floor for questions.
So this is Bill Gibbons. I want to thank you for that. Hopefully not being quoted, but I write one of the up-to-date chapters, okay? And essentially, in the process, I don't know if it was unexplained infertility or endometriosis, they had to list a separate set of recommendations for me because my colleagues were still more interested in doing a gonadotropin IUI. And so I indicated that I would not be willing to do gonadotropin IUI. And I guess the other reason I gave, Richard, is the fact that you're assuming that potentially up-to-date is going to be evaluated by people who are not necessarily subspecialists in reproductive medicine. So clearly I was not interested in trying to have that population start on a population of gonadotropin IUI. And so I'm on the record of not wanting to do gonadotropin IUI. The other thing that we saw, some of the other older data, okay, because I'm old, show that there was essentially about the same chance of success to the first 5 cycles of Clomiphene IUI. And when I first got here, it took us a long time to get adequate numbers of IVF cycles, but we were doing a fair number of IUIs, and when we looked at our data, okay, and it wasn't stratified by age, we had about a 12% chance for clinical pregnancy per cycle, and we saw that, and that held like the older literature through 5 cycles. In fact, the average number of IUIs to pregnancy was 3 because it was 12, 12, 12, 12, and 12. So I think that sometimes you're going to see differences in by the physicians in the room who use 3 cycles versus those who may use 5. And so I'll be quiet while you comment.
Well, first of all, I think you were dead right in your comments up to date because you're right. I mean, I think that it's the specialists that from time to time are those who are still doing the gonadotropin IUI and probably will be the last ones to continue to do gonadotropin IUI and probably in a day. Now, it's really interesting, your comments about the per cycle success rate with Clomiphene IUI. We did a study where we looked at it, and the success rate held the same for us, too, for the first 3 cycles. And we had, and when we went on to gonadotropin IUI, the success rate went up a little bit, not much, but held for 3 cycles. And when we did IVF, the success rate per cycle was the same for the first 4 cycles. So I think you're right when it comes to Clomiphene IUI. I don't think anyone knows the best number of cycles to do, but I clearly agree that based on your data, which makes a lot of sense, that doing more than 3 to 4 cycles may certainly be reasonable. Well, it is reasonable.
So other comments, questions? We have a lot of other smart people here. Dr. McKenzie's here. I know that, so she has a little bit of experience, not a lot, but, so she may have a comment on what they have done. But this was a terrific presentation. We're so thankful for it, okay? I understand. Thank you so very, very much.
Thank you.
I have a question. This is Cecilia Valdez.
Uh-oh.
Uh-oh. Richard, thank you. This was just excellent, and the fellows are very lucky to hear you speaking about this topic. My question is, do you ever have an age group at which you would go straight to IVF and either change the number of Clomid IUI cycles you would recommend or not do them at all?
So,
female age, obviously.
Okay.
It's a great question, and I didn't have time today to really present the data for the 40 trial. And this is our trial where we randomized couples 38 to 43 to 2 cycles of Clomid IUI, then IVF, up to 4 cycles, 2 cycles of gonadotropin IUI, then IVF, and then immediate IVF. When we looked at the comparison of the first 2 cycles, IVF was significantly higher than the other 2 in controlled ovarian stimulation. And when we looked at the chance for pregnancy at the end of the study, 45% of couples became pregnant, and essentially the same in all arms. But again, IVF was a great equalizer. And in fact, of those pregnancies that occurred, 85% of them were from IVF. So I was not there, and I'm glad I wasn't, during the time that they were looking at the data. And they is the practice committee were looking at the data for the 40 trial. But they added that it may be reasonable to go directly to IVF in this older group, where the chance for pregnancy is more limited, and the time for pregnancy is more limited. And it seems like the chance for pregnancy by IVF certainly is sufficient enough to get more people pregnant. So I think in the older age group, my guess is sooner or later we'll come to the conclusion that immediate IVF for others is reasonable. But there's enough data that compares IVF in couples under 38 to the IUI treatments of clomiphene or letrozole that I think that it's still reasonable, and it's so cheap and easy. Why not have 3 or 4 cycles of clomid IUI first? And I think it's the older group that more people are moving to do that.
I have a question. This is Maya Varsky. I'm one of the fellows. When you talked about clomid IUI and then you discussed letrozole, you mentioned that the effectiveness and strength of the studies were pretty similar. Is there a time that you would recommend letrozole initially over clomid or clomiphene citrate due to the lower suggested side effects?
I think that I would recommend it to begin with for those couples who had a bad response to clomid. Now, so from the your question was, would you start with letrozole? I can't think of couples I'd start with unless they had a previous bad experience with clomiphene. And letrozole, at least when I was using it, was certainly sufficiently more expensive than clomiphene. My answer is I don't have the ideal patient to start it with. It wouldn't be wrong to start with it because of the side effect profile, but on the other hand, the literature supports starting with clomiphene.
Thank you.